The Monterey County EMS agency has established a protocol for percutaneous emergency airway or needle cricothyrotomy. You might ask why you need needle cricothyrotomy in the field, and I just thought I'd offer you a few possibilities of why that might be necessary. If you're facing a patient with an airway like this, the chance of you successfully intubating this patient is almost zero. Or you might have a patient like this in which you have massive sublingual and submandibular swelling, or a patient with a soft tissue infection of the neck in which you're not able to visualize the vocal cords. So in any of these situations, you might find yourself in a situation where a patient develops a complete airway obstruction. And in the event of a complete airway obstruction, if you do not establish an airway, that patient will die, which is why we've brought percutaneous needle cricothyrotomy back to the County of Monterey. I think it's important to remember that it's extremely vital for the brain to get oxygen. As we know, within about a minute, brain cells begin to die without oxygen. And within 3 minutes, serious brain damage is likely. Within 10 minutes, many brain cells have already died, and recovery from the injury is unlikely. The victim is unfortunately unlikely to ever regain consciousness. And then once you get to a point in which the brain has not been oxygenated for 15 minutes or greater, recovery is virtually impossible, and the chance of death, brain death, is nearly 100%. So we really have about 3 minutes until the patient sustains serious brain anoxic injury. So this skill is designed to intervene within a reasonable period of time to avoid permanent anoxic injury. And again, you have about 3 minutes to make this decision and to intervene and to get oxygenated blood flow to the brain. The County of Monterey EMS agency has decided to use the Cric devices for needle cricothyrotomy. There are essentially two devices, the Cric 2 and the Cric 1. The Cric 1 on the right-hand side is designed for pediatric patients, and the Cric 2 is designed for adult patients. You'll also need personal protective equipment to perform this procedure and some way to prep the skin prior to the procedure. Other things that you may need for the procedure are an end-tidal CO2 detector. You'll certainly need a bag valve mask or some way to ventilate the patient following the procedure. You'll need some way to monitor the patient, cardiac monitor, pulse oximetry, and most importantly, you'll need a paramedic provider with the courage to perform the procedure before the patient sustains permanent anoxic brain injury. The protocol reiterates the importance of needle cricothyrotomy being a rarely utilized procedure. This is not something that we anticipate paramedics to need to utilize on a regular basis. These are very rare cases, and the indication for needle cricothyrotomy is for patients with a complete airway obstruction that cannot be resolved using less invasive techniques. The needle cricothyrotomy is contraindicated if the patient can either breathe spontaneously or can be adequately ventilated. So any patient who is conscious should not receive this procedure. Any patient who is unconscious but breathing, even if you can't get an endotracheal tube in place or a supraglottic airway, if the patient is spontaneously breathing, they are not a candidate for this procedure. Or if the patient is not breathing and you can ventilate them, they are not a candidate for this procedure. So again, this is a rarely utilized procedure for patients with a complete airway obstruction that cannot be resolved using less invasive techniques. The protocol notes that before performing needle cricothyrotomy, paramedics must attempt all other methods of airway management appropriate for the patient. And we list a bunch of different methods here: patient positioning, jaw thrust, head tilt, chin lift, suctioning the airway, performing back blows or abdominal thrusts for airway foreign bodies, or chest compressions, removal of foreign bodies using McGill forceps, ventilating the patient using a bag valve mask, placement of an oropharyngeal or nasopharyngeal airway, placement of a supraglottic airway device, or intubation are all things that the ALS provider may consider utilizing prior to placement of a needle cricothyrotomy. We do understand that not every patient will be appropriate for all of these interventions. For example, if the patient does not have a foreign body in the airway that can be visualized, using the McGill forceps to retrieve the foreign body may not be appropriate for the patient. And so you don't necessarily need to utilize every single one of these methods prior to going to needle cric, but you should utilize the methods that are appropriate for the patient. And it's important to move through these methods quickly so that you're not taking 15, 20 minutes going through each of these methods before going to needle cric. Because in a patient who cannot be ventilated and has a complete airway obstruction, waiting 15 to 20 minutes to go through these methods prior to needle cric sort of defeats the purpose of performing a needle cric at all. If the methods fail and the patient cannot be adequately ventilated, perform a needle cricothyrotomy as follows. The first thing to remind yourself are the indications, again, for needle cric. The primary indication is the inability to establish and maintain an airway using less invasive techniques. Patients who you are unable to ventilate using a bag valve mask, you're unable to intubate using endotracheal intubation, you're unable to place a supraglottic airway and effectively ventilate the patient through the airway, or you're patients with a complete obstruction of the upper airway that cannot be removed by suctioning, abdominal thrust, McGill forceps, etc. These are the indications for needle cric. Some contraindications for the procedure include patients who are children less than 1 year of age, patients with an injury to the larynx with known damage to the cricoid cartilage, patients with a known laryngeal or suspected laryngeal fracture, patients with a ruptured trachea, anterior neck masses or swelling that completely obscure the anatomical landmarks. These are potential contraindications for needle cricothyrotomy. What are some of the potential complications of performing the procedure? So there are many potential complications. You may not place the catheter in the trachea or airway and therefore not be ventilating the patient properly, which can lead to hypoxic brain injury. There's bleeding or vomiting that can occur, and the patient may aspirate. It's possible to perforate the posterior wall of the trachea during placement of the needle cricothyrotomy. You can injure the thyroid. You can injure the esophagus. You can cause some subcutaneous emphysema, pneumothorax, hypercarbia, vocal cord injuries. Tracheal stenosis can be a potential complication later on. Of course, hemorrhage and infection are all potential complications of this procedure. So the procedure is not one to be taken lightly, but the potential complication of not performing the procedure is permanent brain death. And so when you compare all of these potential complications of performing the procedure with the certainty that if a patient cannot have an airway established beyond about 3 to 6 minutes, that patient will sustain permanent brain injury, which is a huge complication of not performing the procedure. The next step is to make sure you have your appropriate equipment. If you're dealing with a child 1 to 8 years of age, you'll need the Cric 1. And if you're dealing with an adult patient, and in this case, we define adults as 9 years or older, you'll need a Cric 2. You'll note that the Cric 1 has a smaller internal diameter of 2 millimeters, whereas the Cric 2 has an internal diameter of 4 millimeters. Open the package, check your equipment, and have your equipment ready for use. Here, again, are pictures of the two devices. The Cric 1 is utilized for pediatric patients age 1 through 8 years of age. Again, patients who are less than 1 year of age it's contraindicated. And the Cric 2 is utilized for older children age 9 years and older, up through adults. There's some differences between the two devices. The Cric 2 has a distal cuff at the end, whereas the Cric 1 does not. There's a way to inflate that distal cuff in the Cric 2. The Cric 2, you'll notice, also has a green safety clip. And the purpose of this is to advance the catheter so that the needle tip is fully enveloped in the catheter. And when that green safety clip clicks, that's an indication that the needle tip is safely within the catheter, and therefore the risk of perforating the posterior wall of the trachea is much less. The next step is to palpate the landmarks using what's called the laryngeal handshake. You'll notice that the provider here is palpating the laryngeal cartilage, the trachea, and stabilizing the laryngeal cartilage and trachea between their thumb and middle finger while palpating the cricothyroid membrane with their index finger. The most prominent anterior protrusion in the neck is the laryngeal cartilage. And once you palpate that, if you go inferior to that protrusion, you'll come to essentially a divot in the skin and soft tissue, which is the location of the cricothyroid membrane where you'll be inserting the needle. Here's a picture of the anatomy. Again, we have the thyroid cartilage, the cricothyroid membrane, and the cricothyroid ligament. And then you have the cricoid cartilage just below that, just inferior to that. The cricothyrotomy is performed by inserting the Cric through the cricothyroid membrane. Here's another picture of the patient's thyroid prominence, the cricothyroid membrane, and the cricoid cartilage. For female patients, they have a less prominent protuberance of the thyroid cartilage. And so it's important to hyperextend the head and neck as much as possible so that you can palpate the anatomy appropriately. But essentially, the technique is the same. For children, the technique is still the same. You're stabilizing the thyroid cartilage and the trachea between your thumb and third finger, and you're palpating with your index finger to find the cricothyroid membrane. Now that you know where to insert the needle, let's look at the procedure for inserting the Cric 2, which again is the Cric designed for insertion in patients 9 years and older. Positioning the patient is critical so that you can appropriately palpate the landmarks and maximize your chance of success with the procedure. Again, hyperextending the head and neck can be very helpful in exposing the appropriate landmarks. Placing a blanket roll under the shoulder blades and posterior neck can help with this. When you position yourself, you want to position yourself so that your dominant hand is toward the patient's head. If you're right-handed, your right hand is toward the patient's head. If you're left-handed, ideally your left hand is toward the patient's head. Now, I realize that if the patient is in the back of the ambulance, for example, you may not be able to access um, the to the right of the patient, making it difficult for you to position yourself to that side. So this is a procedure that you may want to perform outside of the ambulance, or you may have to modify depending on your environment. Cleaning the skin is the next process. You can use an alcohol swab, you can use betadine. You want to clean the skin as well as possible, but doing it quickly and efficiently. Chlorhexidine can also be utilized for this. The next step is to palpate the landmarks and stabilize the larynx. We sort of talked about this already with the laryngeal handshake. Notice that the provider is using their non-dominant hand for the procedure. They're stabilizing the cartilage of the trachea and larynx between their thumb and middle finger, and they're palpating the cricothyroid membrane with their index finger. The next step is to insert the needle at a 90-degree angle through the skin and cricoid membrane. Once the tip of the needle and catheter penetrated the skin and cricothyroid membrane, you want to change the angle of insertion to 45 degrees. It's important to do this so that the needle tip is less likely to perforate the posterior trachea. Once you've changed the angle of insertion, you can advance the Cric device until the red stopper is flush with the skin. It's a picture of the red stopper flush with the skin while the provider stabilizes the trachea and cartilage with their non-dominant hand. Now that the catheter and red stopper are flush with the skin, you want to make sure that the catheter is in the trachea, and to do this, you aspirate air through the trachea and into the syringe. If the syringe plunger withdraws easily and you have air within the syringe, then you're most likely in the right place. If you get a vacuum or you're unable to withdraw air into the syringe, you're most likely not in the correct location, and you may need to adjust the catheter, or you may need to remove the catheter and repalpate and insert the catheter again. Now that you've confirmed that the catheter is in the right position, you can remove that red stopper. And then you advance just the catheter forward until the green safety clip clicks or locks into place. You'll both feel it click and you'll hear it as well. The point of this is to cover the tip of the needle with the catheter. Notice in this picture that the tip of the needle has retracted or been covered by the catheter so that it's no longer protruding through the end of the catheter. Now that the needle is no longer protruding through the end of the catheter, it's safe to advance the entire device forward until the flange, the plastic flange of the catheter is flush with the patient's skin. The needle can now be removed. The cuff can be inflated. The catheter should be secured, and the patient can be ventilated either directly through the catheter or by connecting a plastic connecting tube to the catheter and the bag valve mask as shown in the picture on the right bottom corner. The plastic connector is included in the Cric 2 kit. That's it for inserting the Cric 2. Let's go over insertion of the Cric 1, which again is utilized for pediatric patients age 1 through 8 years of age. Positioning the patient is even more critical here because these patients have a shorter neck They tend to have more soft tissue around the anterior neck. The anatomy can be more difficult to palpate, and the hole that you're shooting for is smaller. So getting a blanket roll under the shoulders, hyperextending the neck, is crucial for being able to palpate the appropriate landmarks. Position yourself the same way you would for an adult, with your dominant hand toward the patient's head, if possible. Clean the skin, just like you did for the Cric 2. Palpate the appropriate landmarks and stabilize the larynx. Same technique, insert the needle at a 90-degree angle through the skin and cricoid membrane. Once the needle tip is through the skin and cricoid membrane, change the angle of insertion to 45 degrees and advance the Cric trach until the red stopper is flush with the skin. All of this is the same as it is with the Cric trach 2. Now that the red stopper is flush with the skin, we're going to aspirate air with the syringe to confirm that the catheter is in the trachea. Again, same procedure thus far compared with the Cric trach 2. We're going to remove the red stopper. You'll remember that the Cric trach 2 had the green safety clip, but the Cric trach 1, the pediatric version, does not have that green clip. And so you want to advance the catheter only, not the entire device, but the catheter only over the needle until the catheter plastic flange is flush with the skin. Think of this as the same thing you would do for inserting a peripheral IV. You insert the entire angiocath through the skin and into the vessel, and then you insert the catheter only over the needle before withdrawing the needle. Again, you want to be certain that you're not inserting the entire device, but the catheter only. Inserting the entire device risks penetrating the posterior trachea. Now that the plastic catheter has been inserted, you can remove the needle, much like you would with insertion of a peripheral IV. Secure the catheter. Ventilate the patient, either directly or using the plastic connecting tube, again, included in your kit. And that's it. So that is the procedure for both insertion of Cric trach 2 and Cric trach 1. The most difficult part of this procedure is deciding to do it in the appropriate setting. Again, I want to reiterate that this is a rarely utilized procedure. It's not something that we expect you to have to use on a regular basis. And for most ALS providers, you'll never have to use it during the course of your career. But if you find yourself in a situation in which the patient is not breathing, unconscious, unable to be ventilated, has a complete airway obstruction, and you cannot clear that airway obstruction by any other less invasive measures, I want you to have the ability to perform this procedure so that you can establish an airway in a timely manner and hopefully prevent anoxic brain injury and brain death. But the hardest part is deciding to do it. The procedure itself is not overly difficult or complicated. If there's something worse than failure, it's regret. Again, it's important to be ready to do this procedure when or if the time ever comes, and to do it in a manner that prevents the patient from sustaining permanent brain death. That's it for the techniques of insertion of the Cric trach 2 and Cric trach 1. I hope this video has been helpful, and I wish you the best of luck in all of your pre-hospital endeavors. Thanks so much, and thanks for everything you do.